All right, guys, we are going to start lecture. Tonight, we are going to be talking about metabolism. So we are going to break this up into 2 weeks. So your endocrine disorders will be tonight, and then next week will be your diabetes, and I will be recording that for you for next week, so that you guys don't have to have lecture. So Tuesday and Thursday, you will not have lecture of next week. You will just watch your recordings. All right, so let's get started. So learning objectives, we are going to talk a little bit about metabolism. Some of it should be a review probably from your biology classes. We're going to explain how the body utilizes carbs, proteins, and fats for energy, compare metabolic processes the body uses for energy consumption and release, relate nutrition concepts to metabolism, and compare normal and abnormal assessments in clients with metabolic disorders, and discuss risk factors for metabolic disorders. So we know that our metabolism is basically all of the chemical reactions that occur within our body. They give us the energy that we need for other things in our body to work. The whole process of metabolism involves reactions that have to do with degradation, synthesis, and transformation of all of those energy-rich organic molecules into things that our body needs. So we can, oxygen goes in to our body, it comes out as carbon dioxide, water goes in, comes out as sweat and our breath, also as urine. The food that we take in through our mouth comes out through our feces, and then we can take some of our chemical energy and use it for heat. So this is how metabolism works in our body. So through the course of metabolism, our proteins can be further broken down into amino acids. Our carbohydrates can be broken down to monosaccharides and glucose, and our fats can be broken down also to monoglycerides and free fatty acids. So we take in our dietary proteins, our fats, and our carbohydrates through our diet. We swallow them in our mouth. It goes into our GI tract where it becomes hydrolyzed. It breaks down those components, turns them into amino acids, fatty acids, and glucose. And then they are absorbed, circulated, and utilized by the various cells in our body for energy and other things that they need. So anabolism is a process that involves molecules combining together to generate complex molecules. So in order for anabolism to happen, it requires energy in the form of ATP. It can manufacture materials that are needed by the cell. It can make cellular structural proteins. It can also make secretory products. It also can store excess ingested nutrients not immediately needed for energy for a later time. So a good example of that is glucose and our fat reservoir. So if we don't have enough fat, or we go on a diet and stop eating, we have stuff to hold us over. Catabolism is the opposite. It is a set of metabolic pathways that breaks down molecules into smaller units that are then either oxidized to release as energy, or they can use those once they're broken down for other anabolic reactions. It is an energy yielding reaction. It involves hydrolysis, which is one way that catabolism is performed. So it is basically a chemical reaction in which water is used to break down the bonds of a particular substance. An example of a catabolic reaction is digestion and cellular respiration, where during that process, the body breaks apart sugars and fats and in turn uses them for energy. So another metabolic process is oxidation. So this is the process. If a substance is oxidized, it is going to gain an oxygen, lose a hydrogen, and it's also going to lose electrons. So this is just a little example of what happens in the body with glucose and oxygen. So we know that we need things that require energy. We need the ATP. It stores energy and it transfers it for when you need it for other metabolic pathways in the body. We can have energy stored in carbohydrates from our lipids and our protein, which can then be catabolized and then transferred into ATP, which we will use more energy to do other things in the body. So when we talk about food and production of our cellular energy, so it's 3 phases. So the first phase is digestion. We eat something, it goes into our GI system. That digestion process starts. We see these large molecules start to break down. Some of these processes occur outside of the cell, and then they are going to be activated by those secreted enzymes that we talked about a couple weeks ago that are in the GI tract. Then we're going to go to phase 2, which is glycolysis and oxidation. So this is where you guys probably remember this from biology. This is where the glucose is split. Glycolysis produces 2 ATP per glucose through oxidation, which then you can use for energy. And then we have the final phase, which is the Krebs cycle, also called the citric acid cycle. This is where most of our energy is going to be generated. It ends with oxidated phosphorylation, and our end products of the Krebs cycle are going to be CO2, NADH, and FADH2. You guys aren't going to be, I'm not going to test you guys on this. This is just kind of like a little refresher. All right, so our endocrine system. So our endocrine system provides communication with other parts of our body and is going to help regulate processes that will help the body with growth and development. It will help with certain reproductive issues. It gives us energy, and it helps on some levels to control our electrolyte balance. So our endocrine system works to maintain what they call an internal homeostasis and to help integrate all of our body's responses to the external environment that we experience. You guys can look on page, I don't have the page number, but table 34.1, I think it's in chapter 34. Read over endocrine glands with associated hormones and their clinical effects. So our endocrine glands are a collection of specialized cells that work in the body to produce certain hormones that cause an effect at the hormone receptor sites that they're paired up with. So when these hormones are released, they are secreted directly into our bloodstream. Endocrine hormones are different than exocrine glands. They play a vital role in regulating our homeostatic processes. So we said it maintains our fluid and electrolytes, so our sodium, our potassium, calcium, all of those, our urine output, our fluid intake, growth, metabolism. It helps with our sleep-wake cycles, and also there are hormones that make up our reproductive processes. We're going to talk about them a little bit more in detail. So this is in your book. If you guys want to go and look at that, this is the site of action of the hypothalamic and the pituitary agents. So these are all the parts of the body that are involved in the endocrine system with making different hormones. And we're going to talk more about that. So the pituitary gland is connected in the base of, in the brain by a stalk, which is then directly connected to the hypothalamus. Our pituitary gland has 3 lobes, an anterior lobe, a posterior lobe, and an intermediate lobe. It's called it used to be called the master gland because it regulates function of all the other endocrine glands in the body. It used to be that years ago, that's what they called it, the master gland. Well, as scientists started doing more research and more information evolved, now they have designated that the hypothalamus in the body is actually the master gland because it even has more of a regulatory effect on all of those glands. So, let's see. So the anterior pituitary gland, which is right here, produces 6 major hormones. So our growth hormone, our adrenocorticotropic hormone, our follicle stimulating hormone, our luteinizing hormone, prolactin, and then thyroid stimulating hormone, also known as TSH. They also call it in your book thyrotropin. So we're going to be talking a lot about that. These hormones are essential in our body in order for us to grow properly, to be able to reproduce and have babies. And then, of course, we need them for a lot of metabolic processes in our body. Anytime we have a deficiency or an overproduction of any of these hormones, this is when that whole system is going to be dysregulated, and then we're going to start seeing all these issues that we're going to talk about later. We have several exemplars that we're going to talk about. So these hormones are perfect in the right amount, but if we make too many or we don't make enough, then that's when our patients get sick with various illnesses. So our posterior pituitary gland, it is responsible for secreting the hormone vasopressin, which is also ADH. I'm sure you guys remember that from fluid and electrolytes. ADH increases the permeability at the renal distal tubules. When that happens, it causes the kidneys to reabsorb water. So this is your patient that has low blood volume, low blood pressure. If a patient has a deficiency of ADH, it's going to cause diabetes insipidus, which is an excretion of a large amount of dilute urine. Excessive secretion of ADH causes the syndrome of inappropriate antidiuretic hormone, which is SIADH. We're going to talk about these more in detail later. During that process, the kidneys will, instead of excreting the proper amount of water, they do the complete opposite and they retain it. So there's the urine output is very diminished, so their urine becomes extremely concentrated. Their urinary output decreases, and then their extracellular volume increases, so these people have a lot of edema. So some diagnostic tests that we might do, they might do a water deprivation test, which is they look at urine production, blood electrolyte levels, and weight. What they do is they measure them regularly for a period of about 12 hours, during which that time the patient's not allowed to have anything to drink. And they look at how water is regulated in the body. We might look at their ADH levels to see what's going on. We would look at serum and urine electrolytes, and then osmolality as well. And then, of course, we would do urine-specific gravity. So our hypothalamus, which is now the master gland, is going to be located between the cerebrum and the brainstem. It is considered the coordinating center for our nervous and our endocrine system. And it responds to internal and external stimuli. So the hypothalamus directly influences our pituitary gland. So it does that by creating a pathway for various neurohormones to be released, and it can stimulate or inhibit pituitary gland secretions. So when our body is low on something, it will stimulate a certain pathway so that these glands will secrete the needed hormone. And then if we have too much, then it will shut it off. It's that feedback mechanism. It'll stop it so that it doesn't secrete anymore. And it'll just utilize what it has in the body. So we know that the hypothalamus has a huge role in regulating our hormones. It works on that feedback loop. Most hormones are secreted in response to a negative feedback. And like we said earlier, most of our endocrine disorders result when there is an overproduction of these hormones or an underproduction. All right, so there are several hormones that the hypothalamus influences. So our pituitary gland is going to be responsible for secreting TRH, which stimulates the anterior pituitary to secrete THS, or TSH, sorry. CRH is going to be The pituitary gland will secrete CRH. When that is secreted, it's going to stimulate the anterior pituitary to secrete ACTH. The pituitary gland will secrete GnRH, which will then stimulate the anterior pituitary to secrete luteinizing hormones and follicle stimulating hormones. And then GHRH will be secreted by the pituitary gland, which then stimulates the anterior pituitary to secrete GH, which is growth hormone. There are two other hormones involved with the hypothalamus as well. One is somatostatin. Somatostatin is actually an inhibiting hormone, so it's going to stop the process from happening. It's going to shut off the valve so that no hormones can be secreted. So somatostatin actually works to stop the secretion of GH, which is growth hormone. And then we have the what's called hypothalamic dopamine. This inhibits the release of prolactin. So those two, somatostatin and the hypothalamic dopamine, are considered inhibitory hormones. So they stop things from being produced. All right, so our body also has thyroid glands. Our thyroid glands are going to be located in the lower neck, anterior to the trachea, so in the front of, you'll see them when you can feel them. Actually, you don't usually see them unless they're swollen, but they are in the front of the neck. They are considered very vascular glands, and like our lungs, they have two lobes. There's a little space in the middle that is called the isthmus. It's a very small connection between the two lobes that joins them together. It produces two slightly different hormones using iodine that we get through our diet. It's not something that our body makes. So the thyroid will make T4 and T3. So the T4 is also known as thyroxine. I'm not going to say those big names. We never say them in the nursing world. It's either T4 or T3. You just need to know what, we're going to talk more about what they do, but for this slide, I just want you guys to know what the thyroid glands secrete. So they secrete T3 and T4. They also secrete thyrocalcitonin, which is also called calcitonin. And then our T3 and our T4 levels are very important because those levels help regulate our body's metabolic rate. So when our patients have issues with a decreased metabolic rate or a too fast of a metabolic rate, then we know that it's an issue somewhere with the thyroid gland and these T3, T4 levels. And then we have to pull labs and look at these levels to see what's going on. So when our T3 and our T4 levels start to decrease, which means we don't have enough in the body, then the thyroid stimulating hormone, which is called TSH, I keep saying that backwards, is going to be released by the anterior pituitary. This, when that is secreted, it's going to stimulate the thyroid to secrete more hormones until the normal levels are reached. T3 and T4 affect all of our body systems because they help regulate all of our metabolism, energy production. It helps determine and control the way we use our fats and our proteins and our carbohydrates in our body. Calcitonin will work to inhibit mobilization of calcium from our bone, and it's going to help reduce our blood calcium levels because we don't want to have a lot of calcium in our blood. Dietary intake of protein and iodine is necessary for the production of thyroid hormone. So iodine is an element that is needed for the production of the thyroid hormone. Our bodies don't make it, so we have to obtain it through our diet. If you have a thyroid gland that is malfunctioning, you can develop what's called a goiter, which you definitely usually can see that in a person. It's like, and there's a picture in your book. It's a very, very large swollen area in your neck, and it's an enlarged thyroid. So when when there's a malfunction with your thyroid and it's just working overtime, kind of like the heart when we say that there's not enough cardiac output and it has to pump and pump. Same thing with the thyroid. It's always pumping out hormones, always trying to fix things, so then it gets enlarged over time. So this is a good picture of where your thyroid gland is. I don't know if you've ever had a primary care physician do this, but the lady that I do my clinicals with, she always has me go stand behind the patient and always try and feel for their thyroid gland to see if there's any tumors or that if it's swollen for any reason. That's like part of her primary care thing. So it is definitely palpable in your patients. So if you ever see that, you certainly can palpate to see what you feel. This is just a breakdown of where your parathyroid glands are. It just shows you right there. Each thyroid gland has 2 parathyroid glands. There's your trachea. So our parathyroid glands are right here. We just talked about those, right? 2 on each lobe of the thyroid gland. So they are very small, bean-shaped bodies. They are going to be within the lateral lobes of the thyroid. The upper parathyroids are found posteriorly at the junction of the upper and the middle thirds of the thyroid, and the lower parathyroids are typically among the branches of the inferior thyroid artery. Our parathyroid glands do secrete parahormone, which increases the level of calcium in the blood when there's a decrease in the serum level. So we know that our parathyroid, one of the big things it does is control our calcium levels. So this is just kind of like that feedback system. So when the body senses that there is low blood serum levels of thyroid hormone, the hypothalamus, which is that master gland, is going to send a signal to, it's going to send TRH to the anterior pituitary. That anterior pituitary is going to then release TSH, which is that thyroid stimulating hormone, to that thyroid gland. In turn, it's going to respond by releasing the thyroid hormone, T3 and T4, into the bloodstream. The anterior pituitary is also very sensitive to any type of increase in blood serum levels of the thyroid hormone, and it's going to respond by decreasing production and the release of that TSH. So when there's too much, it's going to stop. As the thyroid hormone production and release stops, the hypothalamus will then sense the lower serum levels, and the process is repeated again by the release of TRH. So this is that negative feedback system that we were talking about that helps keep that homeostasis in our body. So this is in your book. This is how the calcium is controlled in the body through our parathyroid glands. All right, so a little further down from our thyroid gland is our thymus. So our thymus is going to be located in the upper part of the chest, above or near the heart. The thymus gland is responsible for secreting thymosin. Thymosin works with, it helps with T cell differentiation, and it enhances immunological function in the body. So basically it works with your immunity. Then it also secretes thymopoietin, which also affects your immunology on some level, but it also works to affect the rate at which your skin ages. So both of these together work together, and they help make those T lymphocytes, which are those white blood cell counts that white blood cells that we need to fight off infection. Usually the thymus in children is a lot larger than it is when you become adults. It does shrink when you start to get into adulthood. So by 25, it's starting to get smaller and smaller. As that shrinks, the amount of T lymphocytes that it is going to produce also decreases as well. And of course, there is a possibility that a person could develop some type of disorder with their thymus gland, but in comparison to all the other Organs in the endocrine system, it's very, very rare. We don't see a lot of them. All right, so we have your pineal and your adrenal glands. So the pineal gland is going to be attached to the thalamus. The pineal gland is responsible for producing melatonin, and we know that melatonin helps regulate our sleep patterns. The adrenal gland is going to be located right above the kidneys. So each kidney has a adrenal gland that sits right on top, and each gland is made up of an inner core and an outer core. The inner core we call the adrenal medulla, and the outer core is called the adrenal cortex. So the adrenal cortex is going to be responsible for secreting our corticosteroids. So the corticosteroids that it makes, there's 3 of them. There are your androgens, your glucocorticoids, and your mineral corticoids. It has a huge function, obviously, with our regulating those levels in our body. And then our adrenal medulla is going to secrete epinephrine and norepinephrine, and it serves as a backup for the sympathetic nervous system. So it gives us that stimulus to either fight or flight. And you can just see here where the pineal gland is located and what it's responsible for. These are your kidneys right here, and your adrenal gland is right here. So that kind of tannish part right there around the blue, that's the cortex. And then that inner part towards the middle, the core there, is the medulla. And like we said, the medulla is responsible for the epinephrine and the norepinephrine, and the cortex is responsible for all of your corticosteroids. When we talk about androgens, we can also say sex steroids. That's what that term is going to be used interchangeably. Just another picture. So this middle part right here, this is your medulla, and then this outer part right here, this is the cortex. All right, so we're going to talk about the adrenal cortex. So if you have a hyperfunctioning, so that means that it is producing too many hormones. If you have a hyperfunctioning adrenal cortex, you're going to have an excess production of cortisol. So you're going to have too many steroids in your body. When that happens, we call that Cushing's disease. And we're going to talk a lot more about that a couple slides down. These patients will present with a moon-like face. So their face is going to be very round, very edematous, very chubby. They're going to have central obesity. So usually their arms and their legs will be skinny, but their mid part will be very heavy. They can also have hypertension. We're going to see protein breakdown in their body faster than it should be. They may also suffer from osteoporosis because it's going to affect their calcium levels. And then females will develop hirsutism. And we're going to talk a little bit more about that in detail when we talk about Cushing's disease. So if you have a hyperfunctioning, so too much cortisol. If you have a hypofunctioning adrenal cortex and a consequent lack of adequate amounts of cortisol, patients are going to develop Addison's disease. So these patients are going to present with weakness, very dark skin pigmentation, kind of like a bronzy color. They're going to have low blood pressure, low BP, weight loss, digestive issues, muscle cramping, increased potassium, and decreased sodium. And they're going to be dehydrated. So complete opposite. Okay, so you guys need to know the differences. We're going to talk more about them. So for issues that are involving the adrenal cortex, for diagnostic tests, we could do something called a dexamethasone suppression test. So this test is going to look to see if there are large amounts of cortisol in the body that are being produced by the adrenal glands. So if a patient was thought to have Cushing syndrome, that is the test we would do. We could do a plasma and a salivary cortisol, where they measure the level of cortisol that's located in your blood or your saliva. They could also do a 24-hour urine collection and check the cortisol levels. We could also check the adrenocorticotropic hormone, ACTH, and we could also do an ACTH stimulation test. So the ACTH and the ACTH stimulation test are two different tests. They do talk about these in detail in your book, so you guys should read over that just to kind of have a good understanding of what the difference is. So when you think a good way, a little reminder for you to think about your adrenal gland hormones, which ones they make the 3 S's. So they make sugar, salt, and sex. So sugar is your glucocorticoids, that's your glucose. Your mineralocorticoids is your salt, and then your androgens. These are also your sex hormones. So the adrenal cortex makes those 3 hormones. All right, so we have our pancreas and our gonads. So our pancreas is going to be located below our stomach, with the head of the gland very close to where our duodenum is. It is considered both an exocrine gland and an endocrine gland. The exocrine portion of the pancreas secretes all those digestive enzymes that we need to break down our food. And then our endocrine portion is going to produce hormones in a collection of tissue that we call the Eyelet of Langerhans. So in that Eyelet of Langerhans, we see 3 different types of cells. We have beta cells, which are going to be responsible for making your insulin. We have your alpha cells, which are going to be responsible for the glucagon. And then we have delta cells. The delta cells are going to be responsible for making somatostatin, which we said a couple slides back is that inhibitory hormone. Our ovaries and our testes, these are very important sex glands, and they all make hormones of their own. The ovaries are going to be responsible for producing progesterone and estrogen, and the testes will release androgens, mainly testosterone. This is going to be responsible for the facial hair that we see on men and the deep voice. And then, secretion of testosterone, estrogen, and progesterone. Those are all the sex hormones. So this is your pancreas here. So just one little small portion, all these little areas on here, this is considered that Eyelet of Langerhans. If you blow it up and you do a microscopic view, you can see in here all the different cells. You have your beta cells, your delta cells, which are the blue ones. The peach colored ones are the alpha cells. And then this is the reproductive system for the women. So this is the ovaries. These long things right here coming off the side, that's your fallopian tubes. Connected to each one is an ovary. The middle part here is your uterus, and then this smallest circle down here at the bottom, that's going to be your cervix. And then, of course, for the men, obviously the penis. Inside the scrotum, this top part here is your epididymis. Then you have your testes, and then your scrotum. So the body does make a couple other additional hormones. We know that in the atria of the heart, we have that atrial natriuretic peptide that can be released. Our kidneys are going to secrete renin and erythropoietin, which is going to help with the maturation of those red blood cells that we need to get that oxygen-rich blood in our body. Our skin also releases hormones. So when we are exposed to sunlight, we have skin cells in our epidermal area that form what is considered to be a precursor of vitamin D. When that process starts to happen, the liver is going to jump in and continue that conversion, and then it's going to move on to the kidneys where it's going to complete the process. when women have a baby, they have a placenta, and it is also responsible for secreting hormones. It's actually considered an endocrine organ, and it does produce estrogen and progesterone. And then we have a lot of different gastrointestinal structures, a lot of epithelial cells and cells that, like gastrin, that secrete different enzymes to help break down our food. So this is that renin-angiotensin-aldosterone system. So it's that feedback system. When we see a drop in our blood pressure or a drop in our fluid volume, our body is going to have renin that is released from the kidneys. It's going to act on angiotensin to form angiotensin 1. And then it's going to act on angiotensin 1 to form angiotensin 2. Angiotensin 2 is then going to act on the adrenal glands to help stimulate that release of aldosterone. And then aldosterone is going to act on the kidneys to stimulate the resorption of salt. And we know that water follows salt. So when then that happens, it increases our circulating blood volume. All right, so when we are looking at these patients and we are doing a history, we want to find out if they have any past medical history of any type of endocrine issues in their family, because endocrine disorders tend to be hereditary. So you need to do a complete family history. So we want to know moms, dads, grandparents, sisters, brothers, aunts, uncles. We really want to know about everyone in the family. We also want to know about their diet and drug history. Some medicines can cause these problems. And like we said, you need to get iodine in your diet. So we really need to know what their diet looks like. So we would want to know, do they have any allergies to shellfish or iodine? We also want to know if they have had a test with iodine contrast in the last 3 months. This is something we would want to ask before the patient has a thyroid test, because it can alter the results a little bit. So we want to assess how's the patient sleeping. Do they feel rested when they sleep at night? Are they extremely fatigued? Are they swollen? Do they have any edema? Are they frequently urinating? Are they having trouble sleeping? Are they noticing any personality changes? Might have to consult family members for that as well, because they might not be able to recognize it in themselves. When we do our physical examinations, we want to make sure that we are measuring their height and their weight. We want to compare it to the last time they were there. If they were there before, this is more something you would do in the outpatient setting. We're going to be looking at their vital signs, checking that blood pressure, heart rate. We want to assess their skin. A lot of these endocrine issues cause a lot of issues for the skin. Changes in the pigmentation of the skin, open areas of the skin, dry patches, oily patches. We're also going to examine excessive hair growth or loss. So sometimes in women, we can see little patches in the head where they're actually losing hair. Is their hair thinning? You can even ask them, have you noticed any change in your hair? Because if it's the first time you've ever seen them, you don't really have anything to compare it to. So then they might say, yes, I noticed that every time I shower, I'm losing a lot of hair. For women, you also want to look at hair in places where it probably shouldn't be. So like on your chin, above your lip, things like that. We want to look at their fingernails. We want to examine them to see if they're particularly thick, if they're thin, do they appear brittle? And then we want to look at their eyes. We're looking particularly for something called Expo Thalamus. I'm going to show you a picture of that a couple slides down. That's where your eyes get very big and they're almost like bulging. And then when we're listening, I said you could go in and stand behind the patient, make sure you're inspecting that thyroid. Do you feel any nodules on there? Does it feel large and swollen? Make sure you're listening to their heart rate and their rhythm. Check their extremities, especially their feet and their ankles, for any type of edema. And then, of course, you're going to listen to their lung sounds, listen for any heart murmurs or advantageous lung sounds. Diagnostic findings that you might do. These are just a few general ones. Basically, the ones you're going to do, we're going to talk about in detail with our exemplars, because it really is just focused on what the patient is presenting with. So I feel like we always do a blood count and a chemistry profile. So we're looking at white blood cell counts, we're looking at red blood cells, hematocrit, hemoglobin. We're going to want to look at their electrolytes, potassium, chloride, sodium, phosphorus, magnesium, all that good stuff. Specifically associated with the endocrine system, we're going to be looking at different hormone levels. So we can look at cortisol levels, we can look at ADH levels, we can look at testosterone, estrogen, and then of course, a lot of the ones that you're going to see are the TSH, the T3, and the T4. So this is a great picture of where the thyroid gland is on the body, and this is how you would actually palpate that if you wanted to. So the doctor can do this, the nurse can do this. I've done it plenty of times with my patients. This is how you would stand behind her, and then you can do it with two hands like that, or you could just do it with one hand and just feel. It takes a little bit of practice, so if you've never really felt one before, you really don't know what you're looking for, but you should try it on yourself or a family member at home and see if you can find out where that is and see if you can palpate it. All right, so sometimes we have to do, hold on one second, sorry. My dog's trying to go out, hold on. Okay. We might have to do CT scans, X-rays, or MRIs. Sometimes we're looking at the neck. Sometimes we're trying to identify tumors. Sometimes we want to see the size of the organs, see where they are, what size they are. Nurse management with regards to diagnostic findings, we're just going to make sure that when they're going for tests, we're going to prepare them for their laboratory and diagnostic testings. We're going to make sure that we explain all the procedures to them so they know what to expect. If they need to be NPO after midnight, or if they have to have fluids because they're having contrast, those are the things that we would make sure we did before. But obviously, this is just a general overview. We're going to talk more in detail with each exemplar. All right. So we're going to talk about exemplars that have to do with the pituitary, the thyroid, the parathyroid, and the adrenal glands. So the first one that we are going to talk about is diabetes insipidus. So a patient will get diabetes insipidus if they have a deficiency of ADH, which is that antidiuretic hormone. So ADH is secreted by the posterior lobe of the pituitary gland. What happens is there is a decrease in antidiuretic hormone, which reduces the ability of the distal renal tubes in the kidneys to be able to collect and concentrate urine. So because the body can't hold on to the urine, they can't concentrate it, the patient is just going to have excessive urination, and all the urine that comes out is going to be excessively diluted. They're going to be complaining that they have excessive thirst. They're definitely going to have an electrolyte imbalance, and they're going to have excessive fluid intake because they're so thirsty and they're drinking so much. So these patients are going to have polyuria, which is them going to the bathroom frequently. They're going to have weight loss, extremely thirsty. They also can be weak because they're going to have those electrolyte imbalances. So they can be dehydrated. So with our dehydrated patients, we're going to be looking for those sunken eyes, might even be a little bit black underneath or brown. We're going to be assessing that skin turgor, looking for that tinting. Their mucous membranes so their gums, their tongue, their cheeks, inside their nose, dry mucous membranes. Because their circulating volume is going to be low, they're going to have tachycardia because the heart is going to be beating faster to get more blood out to bring up that volume. They're going to have hypotension again because that circulatory volume is low. They're going to be very weak, and they're going to have poor peripheral pulses. So when you are checking your patient's pulses, it will not be uncommon for them to have stronger peripheral pulses on the hands than compared to the legs, because remember, the farther you get away from the heart, the harder it is for that blood, that circulating blood volume to be strong in those pulses. So just because it's strong in their wrists doesn't mean that their peripheral pulses are fine. You always need to go down to those lower extremities and do the pedal pulses to see what their pulses are like down there. So for this diabetes insipidus, we would do a fluid deprivation test. You guys can read about this in your book to see exactly how it works. It does determine if the kidneys are going to be able to concentrate urine. And obviously, if they have diabetes insipidus, they will not be able to concentrate urine. So when I say concentrate urine, I just want to reiterate that that means that your body can hold on to it. So when we go to bed at night, if we go to bed at 11 and we sleep till 6 a.m., we don't wake up to pee because our body is good at concentrating our urine. It doesn't have to get rid of it, so it doesn't always give us the urge to do it. So that's what I mean by concentrating our urine. All right, so what laboratory tests would we do? So we're probably going to do a urine chemistry. So their urine is going to be very, very dilute. So if it's dilute, their urine-specific gravity is going to be decreased. Their urine osmolality, so all the particles that are in their urine, their pH, the sodium in their urine, and potassium, and urine volume is going to increase. The urine osmolality is going to decrease. When we look at our serum chemistry, so this is in our blood, it's going to be concentrated because everything is coming out of our circulating volume. So we're going to have increased serum osmolality, serum sodium and potassium, and the serum volume is going to decrease. The serum osmolality is going to increase. Whoops. Sorry. So medical management. So in order to treat these patients, we have to give them a replacement for the ADH, which is not working properly in them. So there's a couple different things we can give. We can give a nasal solution called DDAVP, and we can also give Lipressin or Diapid. These are nasal sprays. They're synthetic drugs that increase ADH activity that reduces the urine output. So you can go to table 50-1 in your book. It's going to talk about if you guys wanted to teach self-administration of that nasal spray to the patient and their families. We can also use a diuretic, which doesn't make sense because they're already peeing too much, but it's a thiazide diuretic. So the patient is still going to secrete water, but it's going to help curtail it, and it's not going to be as much as it was if they were left untreated. And it's actually going to work to reduce the sodium that is excreted at the renal tubules. That's how it works. And then the physicians are going to put in orders to restrict the client's dietary intake of sodium and protein. So they're going to be on a special diet. So this is just a little thing for you guys to look at while you're studying. Basically, it's the kidneys, all this fluid is just coming out. We see this in patients sometimes that have had head injuries, or if they have a pituitary tumor, or if they have had a craniotomy, various amounts of different reasons. The pituitary gland is thinking to itself, I need more ADH to decrease the flow of urine. Signs and symptoms are there. Nursing care is there. It's just something else for you guys to look at to try and get like a mental picture. So for nursing management, you guys are going to want to monitor their vital signs very closely. Strict eyes and nose is going to be a must for this patient because they are secreting so much output. We need to make sure that they're also taking enough in. So everything they take in and everything that comes out. We're going to monitor their central venous pressure. We are going to look at their specific gravity, any type of laboratory studies. So we're going to be looking at those electrolytes, potassium, sodium. We want to look at those kidney functions, bun and creatinine, specific gravity, and then osmolarity. We want to make sure that we are educating the patient to drink as many fluids as they can to replace what they're losing through their urine. And then these are the patients where you're going to weigh the client every day, because we know that weighing them is the most accurate way of measuring their intake and output. And then because they're going to the bathroom so much and they're dehydrated, we're going to make sure that we are giving, checking their skin, giving them lotion if they need it, doing that good mouth care every 4 hours. It's going to be very easy for their lips to get cracked, so we can give them some Vaseline or some type of chapstick that the hospital has to help with their cracked lips. And then some nursing diagnoses that we might see, obviously that deficient fluid volume because of the inability to conserve fluid, and then ineffective health maintenance related to deficient knowledge regarding care of the disease and the importance of medications. All right, so we're going to talk about a couple thyroid issues. So we talked about this earlier. The hypothalamus sits over top of the pituitary gland. The hypothalamus and the pituitary in the brain help control secretion of the thyroid hormones, which in turn helps ultimately control our metabolism in our body. So some patients may present with something called hyperthyroidism, also call it Graves' disease. So this is a hyperactive thyroid. So this occurs when there is a hypersecretion of high thyroid hormones. So the thyroid is making too many hormones. The excessive thyroid hormone is going to exaggerate normal body functions, and it's actually going to make the body be in a hyper metabolic state. So we talk about our metabolism being too low. If our metabolism is too low, then we gain weight. We don't lose. It's hard for us to lose weight. If we're in a hyper metabolic state, then we're probably going to lose weight because our metabolism is too high. So some of the signs and symptoms that you might see with these patients, they might appear restless. They might not know why they're restless. Some of them just say that they report that they feel unsettled. They might report with fatigue. They may appear weak. Some people even report feeling agitated. They may have hand tremors. So hand tremors, especially with our older people, is going to be a cause for safety issues, especially if they walk with canes or walkers. So safety is going to be an issue. Some people get diarrhea. So these patients are going to have an increased appetite. They're going to want to eat everything all the time, but they still experience weight loss because their metabolic rate is too high. Some people report visual changes. These patients, these are the ones that are going to present with that Expo Thalamus. I'm going to show you that. I think there's a picture. Photophobia. And then these patients might get a goiter, which is this middle area here in the neck area that gets very swollen. Some of these patients will report with a heat intolerance. They might be tachycardic. They might say they're having heart palpitations. They may be short of breath, either at rest or with exertion. They can be warm, sweaty. They're going to have flushed skin with this velvety, smooth texture. They could also report hair thinning and the development of fine, soft, silky textured hair in different areas of the body. Not every person presents with all of these signs, but these are all the possible signs. All right, so diagnostic findings, we might do a thyroid scan or we might do an ultrasound to see the measurement of the thyroid, to see what's going on with it. Our laboratory findings, we are going to be looking at the T4 and the T3. The T4 and the T3 levels are going to be elevated. TSH levels are going to be decreased. We're going to talk about this on the next slide. So this is where people get confused. They're like, well, why aren't they all increased if it's making too much? So with hyperthyroidism, T4 and T3 is elevated, but THS is decreased. We could also look at certain immunoglobulins that are specific for the thyroid, and we can also look at certain thyroid receptor antibodies. Page 897 in your book, table 50.1 talks about symptoms of thyroid dysfunction. You can also look at figure 50.8, which is great for you guys, page 904. This is going to give a nice comparison of the signs and symptoms that would be presented with hypothyroidism versus hyperthyroidism. All right, so just to recap, our pituitary gland is going to monitor the thyroid hormone level in our body. When the thyroid hormone levels get too low, the pituitary gland is going to produce more TSH. So you will see an elevated TSH level in hypothyroidism. So that should make a little bit more sense to you. So if your thyroid hormone levels are low, then your pituitary gland is going to make more TSH. If your thyroid hormone levels are high, then the pituitary gland is going to stop making TSH. So if you have hyperthyroidism, your TSH is going to be decreased. When the thyroid hormone levels get too high in the pituitary gland, is going to produce low amounts of TSH due to the excess amount of thyroid hormone already in the bloodstream level. And the TSH levels will be low in hyperthyroidism. So I made this little chart here for you guys. So hypothyroidism is on the left, hyper is on the right. So your TSH for hypo is going to be increased. For hyper, it's going to be decreased. Your T4 and your T5 levels with hypo are going to be decreased. With hyper, they're going to be increased. So think of it this way. With hypothyroidism, the thyroid is trying really hard to stimulate because there are low levels of T3 and T4. So it's working overtime because the levels are not appropriate. With hyper, the thyroid isn't stimulating because we have high amounts of T3 and T4 that are already circulating in the body. So here is what I was telling you guys about the, the bulging eyes. They present with, that's a pretty common finding. They're going to have swelling and heat intolerance, muscle wasting, thinning hair, insomnia. They might have this goiter. You see how her neck is swollen right there? We would call that a goiter. We're going to see these heart issues, so tachycardia, palpitations, weight loss, but this increased appetite. And then they're also going to have this fine tremor in their hands. And here is just another slide for you guys. Oops. You can just look at that. I just like to give you guys a comparison. So how do we treat hyperthyroidism? So we can give thionomides. Thionomides work to inhibit the production of the thyroid hormone. So the two that we mainly see are tapazole or PTU. We can also give radioactive iodine therapy. So this is where radioactive iodine is going to be taken up through the thyroid, and it's going to destroy those hormone-producing cells. Radioactive iodine therapy is going to be contraindicated for women who are pregnant, so it's not safe when you're pregnant. If you are taking this therapy, you would want to stay away from children and pregnant women 2 to 4 days after you received your dose to avoid any exposure to them. You do not want to use the same toilet as other people for 2 weeks because it's going to come out in your urine. When you do use the bathroom, they recommend that you flush the toilet 3 times after each use. And then patients should wear clothing that is washable. You want to wash your clothing separate from anybody else in the house. And then after you're done washing your clothes, you should run the washing machine cycle after washing that contaminated clothing to clean all the residue out of the washing machine. You can look at table 50.1, which is going to talk about these two medications. And then on page 898 also talks about thyroid disorders. So sometimes medical management isn't enough and we have to do surgical management. So there's a couple different things you can do. You can do a subtotal thyroidectomy or a total thyroidectomy. So with a subtotal thyroidectomy, this is going to be performed for patients, obviously, that have hyperthyroidism when their medical treatment has failed. Same thing for a total. The difference with a total is that these patients are going to need lifelong thyroid replacement therapy. So there's a lot of education that needs to be done with them because we need them to understand the importance of being compliant with their medications. So these patients that have these thyroidectomies, they need a lot of teaching post-surgery. We want to make sure that we are instructing the client to make sure they're supporting their neck when they're performing deep breathing and when they're doing coughing exercises post-operatively. If you go to your book, figure 50.7 tells you exactly how you would want to educate the patient to use their hands to support the head. These patients are at a high risk of developing respiratory distress because this area where they had the surgery becomes very edematous. And because it's so close to your bronchial area, the swelling causes a lack of air to be able to get in and out. So respiratory distress is something that we're going to watch out for. Sometimes we see the effects on their vocal cords from the surgery. So they experience laryngeal nerve damage. So these patients may sound like they have a hoarse voice. They may sound very breathy when they talk. Their voice also might sound very weak. And then aspiration and pneumonia is also possible for these patients. When they're doing this surgery, if by any chance the parathyroid glands are damaged or removed in the process, our patients are then at a higher risk of developing hypocalcemia and tetany. So these patients you would want to observe for muscle twitching and tingling around the mouth and toes. All right, so some patients can develop a what's called a thyroid storm or a thyroid toxic crisis. These two terms are used interchangeably. Patients will develop a thyroid storm when a sudden surge of large amounts of our thyroid hormones are dumped into the bloodstream. This is considered a medical emergency and it has a very high mortality rate. So if this is something that your patient develops, you need to know you have to contact the doctor and that it's a medical emergency, it's life-threatening. We see this happen to our patients after they have thyroid surgery, when there's some type of manipulation of that thyroid gland. What's happening is that the body is over-secreting. Hold on one second. Ryan, I need you to get the dog. There's an oversecretion of T3 and T4, followed by a release of epinephrine at the same time, and then our metabolism is going to go through the roof, way higher than in that hyperthyroidism. So the metabolism is going to be markedly increased, and our adrenal glands are going to produce excess amounts of corticosteroids. So these patients are going to present with an extremely high fever, hyperthermia. So their temperatures can get as high as 106 degrees. They're going to have a very rapid pulse. They're going to be dyspneic, so short of breath. They can experience heart palpitations. They're going to have hypertension, so their blood pressure is going to be extremely elevated. They're at a risk for developing cardiac dysrhythmias, nausea and vomiting. They might even experience delirium. So things that we would want to check out, well, we would want to know, do they have a history of any hyperthyroidism in the past? Have they had any recent thyroid surgery that could have caused this? The laboratory tests that we look at would be T3 and T4, and these are going to be markedly elevated. So medical management, we know that this is an emergency situation and immediate treatment is going to be necessary. So the doctor is probably going to order those thionamides to help prevent further synthesis and release of the thyroid hormones. The patients are going to be getting IV. Ryan, yeah. I need you to take the dog and let her out back. She keeps barking, and then keep her in your room. IV corticosteroids may be given to replace the depletion that comes from overstimulation of the adrenal glands. Remember, we said they're going to be secreting large amounts of corticosteroids, so then these levels are going to be low. We know these patients have extremely high temperatures, so we're going to give them acetaminophen to help bring down the hypothermia. They're going to have hypertension, so we're going to administer beta-blocking agents. Propranolol is one of the major ones that they use because it helps block the sympathetic nervous system effects. Obviously, we're going to be giving IV fluids to help maintain adequate hydration and prevent vascular collapse. And then we are going to give supplemental oxygen to meet, because the body, the higher the metabolism goes, the more of an increased oxygen demand we have. And these patients can get very short of breath, so they're going to need oxygen. And then we want to remember to never give aspirin to a patient with that's having a thyroid storm, because it increases their thyroid hormone levels. So that is not something we would want to give them for their fever. All right, so some nursing diagnoses that we may see: anxiety related to increased stimulation, loss of control, diarrhea related to that increased gastric motility, insomnia related to anxiety, excessive sympathetic discharge, imbalanced nutrition, less than the body requirements related to increased metabolic rate, increased gastrointestinal activity, risk for injury, eye damage. Risk factor is the protruding eyes without sufficient lubrication. So these patients do require a lot of lubrication drops in their eyes because they're always open all the time. They get very, very dry. They do complain about that all the time. And then obviously risk for unstable blood pressure related to the hyperthyroidism. All right, so now we're going to talk about the complete opposite. So hypothyroidism. So hypothyroidism is the complete opposite. This is where the thyroid gland fails to secrete enough thyroid hormones. So the body has an inadequate amount of T3 and T4. This is going to cause a decrease in our metabolic rate that is going to affect all of our body systems. So we're going to see the complete opposite of everything that we saw with hyperthyroidism. So we're going to have a very slow metabolic rate. So these patients are going to report weight gain. They're going to be fatigued. They might be experiencing lethargy. So the weight gain, you're going to want to ask them, are they increasing their caloric intake? What's going on? So these people are going to say, I'm still dieting, I'm doing what I'm supposed to do, I'm still gaining weight. They are going to have constipation. So if you guys know what the thyroid does and what it controls, it'll be very easy for you to understand exactly what problems are going to occur if there's an issue. Our temperature and our pulse are going to be decreased. We're going to have very dry, thickened, pale skin. Sometimes these patients, their tongue becomes enlarged, their lips get swollen. They could even have periorbital edema, which is edema of the eyelids. In women, we might see menstrual disorders, so slow thought processes with some patients. Some patients complain of chronic headaches. They are going to have an intolerance to cold. So freezing cold all the time. They're going to present with very thick, brittle fingernails. They might have a very hoarse, raspy voice, sound like they smoke some cigarettes. Can you guys hear me? Yes, okay. It just keeps telling me my internet's unstable. Their hair is usually going to be very coarse and sparse. So you might have spots where it's not as thick and it does tend to fall out. Their face, sometimes they report that it takes like a mask-like unemotional expression, and the client is often irritable. They can develop an enlarged heart, atherosclerosis, anemia, bradycardia, and hypotension. So the complete opposite of everything with hyperthyroidism. So being able to recognize this is early in the stages when it first starts is kind of hard because a lot of these symptoms are just kind of like non-specific and people just blow them off as occurring for varying different reasons. So they don't really address them. Or they're not bad enough that it makes them come into the doctor. So it is very common that this condition goes untreated for many, many years. So of course we are going to we want to look at our thyroid function levels. So we want to look at our TSH. Our TSH is going to be increased because low levels of thyroid hormones are going to cause the pituitary to increase the secretion. And then our T3 and our T4 is going to be decreased. And we're also going to see an increase in our serum cholesterol levels. So some diagnostic tests. We may do a radioscopy scan, radioisotope scan, and an intake. This would show a low uptake of iodine. We probably want to do an ECG because they're having some arrhythmias there, dysrhythmias, palpitations. That might show that they are suffering with bradycardia, so that low heart rate. So this is the patient with hypothyroidism, very, very, very cold all the time, receding hairline, facial and eyelid edema, dull blank expression. I'm not sure that I've ever really seen that, but your book talks about it, and so does this. Generalized edema, thick tongue, so it might sound like they're speaking slowly, lack of appetite, brittle hair and nails, menstrual disturbances, hair loss, lethargy, dry skin, muscle aches and weaknesses, and then constipation. Those late manifestations that you would see are going to be that subnormal temperature, super low, bradycardia, weight gain, decreased level of consciousness, cardiac complications. So medical and nursing management, we are going to give these patients a low dose of thyroid hormone. Levothyroxine is what we give. So a low dose is given first when they first start, and then they increase the dose every 2 to 3 weeks until they achieve their optimal dose. So they're going to keep giving this medication, upping the dose, doing more labs, looking at the TSH, the T3 and T4, and then when it gets to the right level, then they will stay at that dose, and that will be their maintenance dose. We are going to want to monitor for any type of cardiovascular changes. So we know they have low blood pressure. So if they have low blood pressure, their circulating volume is low. So they're at a high risk for developing dysrhythmias. Their organs may not be being perfused as they normally should either. So their kidneys, liver, things like that. We want to make sure that we are giving the patients anti-embolism stockings, and we're elevating the client's legs to assist in venous return. So like I said earlier, if your heart is not pumping like it should be, or if there's not enough circulating volume, it's going to be very hard for the heart to pump it out and to get it, throughout your entire body, all the way down to your lower extremities and back up to your heart again. So those anti-embolism stockings, they're going to go on the legs and they're going to squeeze and compress the legs They're very, very tight, and it's going to help shoot that blood back to the heart so they don't develop any type of blood clots. We want them to have a low-calorie, high-bulk diet because remember, they are at risk for constipation and they are already gaining weight, so low calories. And we want to encourage fluids and activity because of the constipation. Meticulous skincare, and then provide extra clothing and blankets to clients who have who have cold temperature, that complain of cold temperature. All right, so some nursing diagnoses that we may see: activity intolerance related to muscular stiffness, shortness of breath on exertion, constipation related to decreased gastric motility, impaired gas exchange related to respiratory depression, impaired skin integrity related to edema, dry or scaly skin, and then risk for overweight. Risk factor, decreased metabolic processes. All right, so some of our patients can develop tumors on their thyroid. So tumors on the thyroid can cause hyperthyroidism. Most of the tumors that we find are usually benign, but they have to all be evaluated. So if you are examining your patient and you feel a nodule on their thyroid, you have to refer them. And depending on the size, I forget exactly what the parameter is, but once it gets to be a certain width, or depending on how many they have at the time, that's when the surgeon says, okay, we're going to go in and do a biopsy and see. So most of them are benign, but not all are. So they can develop two types. So they can develop what's called a follicular adenoma. These are the most common types of tumors that we see, and these are benign. They can also develop a papillary carcinoma. So this is a malignant tumor, and this is the most common malignant tumor that we see in these thyroid tumors. Usually we see these papillary carcinomas in patients who have had any kind of radiation treatment to the head or the head area in the past. So if they've had any kind of brain cancer or anything like that, then they develop this papillary carcinoma. So assessment findings, they're going to have a very nodular thyroid. So if you actually palpate it, you're going to be able to feel mostly all those little nodules that are on the thyroid. Their voice might sound hoarse. They may also report difficulty swallowing. When you're doing your physical examination, you want to make sure you're palpating and then also see if you can visibly notice any neck swelling in that area where the thyroid should be. And then ultimately, depending on the size or how many they have, the doctor may decide to do a biopsy to confirm if they're benign or cancerous. So depending on what happens with them, if they have to be biopsied, the patients might need a thyroidectomy. They might need thyroid hormone replacement therapies. They might need radiation. It just depends the outcome. So these patients, obviously, if they have cancer, they're going to require some emotional support. So the nurse wants to make sure that she's present with the patient and listens to the patient and gives them the support and their family members the support that they need, because obviously that's a difficult time. When you're caring for these patients, if they are having radiation, you are going to have to be very careful to prevent any type of radioactive contamination because you're handling their body fluids. And if you were taking care of a patient that had radioactive therapy, your unit would tell you exactly what you needed to do to take care of them. You can also read in Chapter 18. It's going to talk to you about different radiation procedures postoperatively and things that the nurse has to look out for. All right, so thyroiditis. So this is when our thyroid gland becomes inflamed. So there's two types, acute and subacute. Acute thyroiditis we usually see in children, most common in children, and it usually comes after they've had a bacterial infection of some sort of the gland. Subacute or chronic, it's either subacute or chronic. We call that Hashimoto's. Hashimoto's is an autoimmune disorder that develops in women in the postpartum period. So these patients are going to present with high fevers. They're going to be extremely tired. They will have tenderness and swelling of the thyroid gland when you palpate it. Diagnostic findings, a thyroid scan to look at the size. Lab test would reveal an increased white blood cell count, probably because there was an infection there. Medical and surgical management, obviously they're going to get analgesics to help with that high fever, corticosteroids to help take down the inflammation because the thyroid gland is inflamed, and then antibiotics with those children if there was some type of bacterial infection. Sometimes if they have Hashimoto's, they will have to have hormone replacement therapy. And sometimes if the gland gets too large, they have to go in and do surgery to remove it. So nursing management, we would want to give antipyretics for the fever. We're going to make sure we're elevating the head of the bed if they have difficulty breathing, because the larger this gets and the more inflammation we have, it can compromise the airway. So they are definitely at risk for respiratory distress. And then sometimes they report difficulty swallowing. Not every patient does, but depending on the size, you have to have a soft diet, maybe even a full liquid diet, or a clear liquid diet if they are not able to take soft food. So it just depends on the severity of the inflammation. All right, so now we're going to talk about the parathormone. So this is an excess of parathormone. So this is a picture here at the top. This is what a normal parathyroid gland looks like right there. And then you can see the parathyroid gland over here to the right is extremely enlarged. So it is either going to be hyperparathyroidism is going to be a primary condition or a secondary condition. So the cause of a primary condition would be an adenoma, which is a benign tumor. It's going to, you can also see it because of increased secretions of PTH. What's going to happen is it's going to remove calcium from our bones. Our bones are going to become demineralized, and then it's going to enter the bloodstream. A secondary cause would be if we have an increase in our parathyroid hormone secretions in response to hypocalcemia. So we don't have enough calcium in the blood, and it's going to keep secreting and keep secreting and keep secreting. So these patients, they will present with fatigue, hypotonic muscles. They may report skeletal tenderness, and then when they stand up, when they're weight bearing, they may report a lot of pain and discomfort. Because of the calcium issues, they are going to be at a high risk for cardiac dysrhythmias, and then also for pathologic fractures because they don't have enough calcium. Nausea, vomiting, constipation. So a common finding with a lot of these is fatigue. So that's probably not going to be the only thing I give you in regards to signs and symptoms. You know, because fatigue is pretty much common with all of these. So I will be pretty specific about the signs and symptoms, and you should be able to, if you know these disease processes, differentiate. So diagnostic findings, laboratory tests, calcium, phosphorus, and a 24-hour urine. So the calcium is going to be elevated in the blood, decreased in the bones. The phosphorus is going to be decreased. And then our 24-hour urine is going to show an increase in our urine calcium. So the calcium in our bones will be low, but the urine in the blood will be elevated. We could do an MRI or a CT scan if we need to. That would show that this patient had a calcium loss from their bones. And then medical management and surgical management. So if it's secondary hyperparathyroidism, we would just want to correct the cause. What's causing the problem? We would want to replace their sodium, replace their phosphorus. We want to make sure they have a diet that is restricted as far as calcium goes. And then if it's primary, then really what we would have to do is surgical removal of that hypertrophied area of the thyroid gland. Or if it was a tumor that was on there, you would want to remove the tumor or one of the parathyroid glands if you had to. It just depends on what the situation was. So nurse management. So we as nurses are going to make sure we're monitoring their eyes and nose. We are going to be screening for urine calculi. So we're going to be straining their urine because it is possible that they can pass stones. We're going to assess for flank pain, which is common, something that we see when patients have kidney stones. We're going to monitor for self-care deficits. Remember, these patients are very weak. It's going to be hard for them to take care of themselves. We obviously want to promote a safe environment. If they are not having trouble taking care of themselves, they are at risk for falling. We want to encourage fluid intake because we want to keep that urine dilute because we don't want those urinary calculi. We want to encourage rest periods for these patients. So We don't want them running to tests and then working with PT and working with OT, doing things like that in the hospital. We want to give them ample time we want to cluster their care and give them adequate rest periods. And then if they do have surgery, obviously, depending on what they did, we want to provide post-operative care. And then we want to educate these patients. So if they have it removed and they require lifelong hormone replacement, we want to talk to them about how important it is that they understand that it's lifelong and that they always have to take their medicine as prescribed. Clients with hyperparathyroidism should be on a low calcium diet. So we know calcium is mostly found in our dairy products. So we don't want them eating a lot of dairy products. They should drink at least 3 to 4 liters of fluid daily to help dilute that urine and prevent renal stones from forming. And it is especially important that they drink fluids before they go to bed and periodically through the night, because we don't want them to have that concentrated urine, because when they have the concentrated urine, they're at a higher risk for developing the renal stones. All right, hypoparathyroidism. So this is the complete opposite. So this is a deficiency of para hormone or trauma to the glands. If they've had some kind of trauma to the glands, it's going to cause hypocalcemia. These patients, the signs and symptoms that we see are going to be directly related to the low calcium levels. Those low calcium levels are going to affect our neuromuscular functions. So the main acute symptom that we see in these patients is tetany. So patients can report numbness and tingling in their fingers, around their toes, and sometimes around their lips. They might have voluntary movements, like moving their arm or leg a certain way, but that's also going to be followed up by involuntary movements. They might report muscle cramping, and then they can have tonic flexion of an arm or a finger, which is very, very common. So this is just where that extremity becomes continuously contracted and they're not able to move it. These patients are also going to have a positive Diagnostic and Trousseau sign. So to elicit this sign in your patient, you would go over and tap the patient's facial nerve, which is going to lie under the tissue in front of the patient's ear. When you do this, it's going to, the client will, their mouth is going to twitch and their jaw is going to tighten. It does go into detail in your book about that, so you guys should look at that. They can also experience what's called a laryngeal spasm. So when they experience that, this is going to cause them to possibly go into respiratory distress because of the dyspnea. They're going to have dyspnea with these long crowing respirations because the air is trying to pass through an area that is very, very constricted. So it's going to make this really scary sound. Almost like stridor, but not quite like stridor. All right, so diagnostic findings. Well, we're going to see that our serum calcium is decreased. Our serum phosphorus is increased. Remember, serum and phosphorus and calcium work on opposite ends of each other. So if one is up, the other one is down. So serum calcium is decreased, phosphorus is increased, urine levels of calcium and phosphorus are going to be decreased. If we did any kind of x-rays or radiographs, it's going to reveal that they have an increased bone density. And then to medically manage these patients, we're going to give them IV gluconate, which is an IV calcium salt. Depending on that laryngeal spasm, what's going on with them, they might require endotracheal intubation. They also might require mechanical ventilation, so they're going to be in the ICU for that. And these patients are going to be taking long-term supplements of oral calcium. So nursing management, we are going to make sure that we are assessing and being alert for the signs of tetany, and we're going to assess for that Diagnostic and Trousseau sign. We're going to administer the IV calcium salts that were ordered. Because of that laryngeal spasm and the fact that they can go into respiratory distress and require intubation, we want to keep an emergency tracheostomy tray at the bedside. We want to make sure that we have mechanical ventilation equipment available in the room. We want to make sure we have an artificial airway and endotracheal intubation equipment at the client's bedside. That should all be there, and that's something you want to make sure you have every shift during shift change when you're getting report on your patient. You want to make sure you're assisting these clients with activities of daily living, so helping them cut up their meals if they need to, helping them eat, helping them shower every day, get dressed. These patients tend to have they need more calcium and vitamin D than they can actually get through their diet. They should still be encouraged to eat foods that are calcium rich, so our dairy products, yogurt, milk, green leafy vegetables, fortified orange juice, but they're also going to have to take supplementation as well. The diet just isn't enough. We want to make sure that we are encouraging them to avoid carbonated beverages because they're very high in phosphorus. And then it is critical to stress the importance of these two aspects of treatment. This is big patient teaching here. And this is going to be a lifelong issue. So they really need to understand, and their family members. And if they're in the hospital, you might have the dietitian come by and give them a list of foods that they can have in their diet to take home with them. All right, Addison's disease. So Addison's disease is adrenocortical insufficiency. This is caused by some type of damage or just a dysfunction of that adrenal cortex. So we know that the adrenal cortex is responsible for producing mineralocorticoids, glucocorticoids, and aldosterone. So the production of these corticosteroids, everything's going to be diminished, which is going to result in decreased aldosterone and a decreased level of cortisol. So again, this can occur primarily or secondary. So if someone develops Addison's disease as a primary disease, it's going to be because there's been some type of destruction to the adrenal cortex. Usually it comes from a patient that's had tuberculosis, or if they have an autoimmune disease and the body sees it as a foreign object and the body starts attacking it and destructs it. Usually the consequences that we see from that primary disease state is going to be decreased available glucose available in the body. So these patients are going to have hypoglycemia. If it occurs secondarily, this is going to be because it was a surgical removal. Maybe they had a stroke, a hemorrhagic stroke, where they were bleeding. It can come from hypopituitarism, certain medications. So being on corticosteroids for a long time or high doses of corticosteroids can also cause suppression of the adrenal function. All right, so what will we see? We're going to see our primary symptoms occur gradually. Secondary symptoms that we see usually tend to develop a lot faster. So your primary symptoms are going to be, well, I would say that these are really pretty much all the same symptoms for primary and secondary. It's just that if it's a secondary issue, they're just going to happen quicker. So weight loss, and again, not every patient presents with all of these, it just depends. They might report that they're having a craving for salt, hyperpigmentation of their skin, they're going to be abnormally dark, weakness and fatigue, hypothermia. They can complain of nausea and vomiting. They might have abdominal pain, GI symptoms, anorexia, so they're not going to have much of an appetite, which explains the weight loss. Together with the nausea and vomiting, they're going to have severe hypotension. So we know that if their circulatory volume is low, they're going to have decreased cardiac output, a weak, irregular pulse. We're going to have orthostatic hypotension. Remember, when they change positions from laying to sitting to standing, we're going to see that blood pressure drop systolically and diastolically. They might be dehydrated. They may report that they feel nervous. They may also express periods of depression that come out of nowhere. And then they are going to have increased urination excretion of sodium. So they're going to be getting rid of a lot of sodium, but they're going to be retaining potassium, followed by dehydration and reduced blood plasma volume. So these patients are going to have hyponatremia, hypoglycemia, so low blood sugar, low sodium. They're going to have hyperkalemia and hypercalcemia, so increased potassium and increased calcium. So you know that patients that have increased calcium, especially potassium, are going to be at a higher risk for all those heart issues. So these are your patients that are going to be hooked up to a cardiac monitor. And then, so you guys should also probably review your electrolytes for this test just to know what symptoms you would see with these different electrolytes. All right, so what kind of tests would we do? We could do an ACTH stimulation test. This is different than the ACTH test. So this is where they have ACTH that stimulates the patient's adrenal glands to release two hormones, cortisol and adrenaline. Adrenaline is also known as epinephrine. Those two are used interchangeably. And then it's going to measure how your adrenal glands react to that ACTH in your blood. If we are doing lab values for electrolytes, we know that we're going to see an increase in potassium, an increase in calcium, but a decrease in sodium. Their BUN is going to be increased. Their blood sugar level is going to be decreased. And then if we did any kind of diagnostic findings, so any kind of radiological imaging, we would just do it to try and just further diagnose actually what the source was of the adrenal insufficiency. So medical management, these patients don't have a lot of cortisol in their body, so they are going to need daily corticosteroid replacement. And it's also going to act as an anti-inflammatory. These are going to be required probably for the rest of the patient's life. So these patients need a lot of education about being compliant with this medication. One of the medicines that we see that's used as a replacement is something called fludrocorticoid, also Florinef. So this is one of the main, this is like the drug of choice. There's other ones out there, but this is the one I see prescribed most often. So for nursing management, what are we going to do? We're going to be mindful to monitor those fluid deficits, monitor those lab values, those electrolyte imbalances. We need to know what signs and symptoms to look for with the hypoglycemia and hyperkalemia and hypercalcemia. Nursing diagnoses, so activity intolerance related to weakness and fatigue, disturbed body image related to increased skin pigmentation, deficient fluid volume related to failure of regulatory mechanisms, imbalanced nutrition, less than body requirements related to chronic illness, and then risk for injury, risk factor weakness. So this is your patient with Addison's, depression, hypoglycemia, postural hypotension. They're going to have anorexia, weight loss, bronze pigmentation of the skin, increased heart rate, GI disturbances, weakness, and fatigue. This is just another picture that I took from your book for you guys to look at. All right, so sometimes our patients will get what's called an Addisonian crisis, or it's also called an acute adrenal crisis. So any patient that previously had a primary or a secondary adrenal insufficiency is at risk for developing this Addisonian crisis. This is a life-threatening condition. If it is not noticed and it is left untreated, it can be fatal. So this occurs when the adrenal glands just fail to operate. It can develop We see it happen in patients that are dealing with extreme stress. So examples of extreme stress would be hypoglycemia, anything that's going to put stress on the body. If they're septic from a bacterial infection, if they were on steroids, but then we stopped them abruptly without weaning them off. So one thing about steroids is you always wean them off. So if they take them for 2 weeks, and then by the third week, they might take, if they were taking 3 pills a day, they might take 2 pills a day for 2 days, and then the next day they take 1, and then for 3 more days they take a half, and then they're completely done. If you take those steroids from them very suddenly, then that's when you're going to be dealing with some of these disease processes that we talked about tonight. Sometimes it will come if a patient has had surgery and they've been through anesthesia, everything goes to sleep. So these glands are no different. Hypothermia, if they have a low circulating volume. So if they had surgery and maybe they're hemorrhaging, if they had a heart attack, any kind of trauma, or salt deprivation as well. So anything that's going to cause the body to have extreme stress. Again, this can be very sudden. It can just come out of nowhere, or it can be gradual. So these patients are going to report anorexia, nausea, vomiting, diarrhea, abdominal pain, hypotension, so low circulating blood volume, fever, weakness. They might report that they feel restless. They might look restless in the room. They might be moving all over the place. It's hard for them to sleep. If this is not recognized and they do not administer steroids to the patient, the condition is going to continue to get worse. The patient is then going to be in an acute adrenal crisis. Their blood pressure is going to rapidly drop, and then shock is going to develop. And then this is where the patient could die. It's fatal. So diagnosis, really, we just have to kind of go off the symptoms that we see and what we know about their history. All right, so medical management, obviously we're going to administer corticosteroids. We're going to administer hydrocortisone IV. It could come as a bolus, and it can also be a continuous treatment or an intermittent. So we could just give the whole bag very rapidly. When we say a bolus, it means that it's not going at a predetermined rate. So it's not going at 100 mLs or 200 mLs. It's wide open and it's going in as fast as it can. It can be that continuous infusion where it's just going around the clock, or it can just be intermittent, that we give it at different parts during the day, depending on how bad it is. Never, ever, ever. So as nurses, we have to really take into consideration, look at our patient load, look at their meds in the morning. This is not a patient that you want to go to late. So these medications need to be given at the ordered time. So this is a patient that you would want to see first if their medication was due at 7 or 8 in the morning, and then never, ever, ever omitly or abruptly discontinue. So if the doctor orders, you see an order come through that says that they're not, usually what they do is they transition from an IV dose to a PO dose, and they usually go home on that. So if you see that IV dose get discontinued and you don't see a PO dose in there, that's something that you guys would probably question the doctor about, because you can't stop these abruptly. Patients that, these patients are at a high risk of infection, so we might give them prophylactic antibiotics. They're going to have hyperkalemia, so we can administer sodium polystyrene sulfonate, which will help bring down the hyperkalemia. We can give insulin, because insulin will carry the potassium with the glucose. We can give them calcium, and we can also give sodium bicarb. It just depends on what the doctor orders. And then obviously we want to treat the hypoglycemia. So we want to do frequent checks of their neurological status. Once we start talking about diabetes next week, you guys will understand more about hypoglycemia. But patients that have low blood sugar can become very disoriented. So if we have a patient that loses consciousness in the hospital, that's one of the first things we do after we call a rapid, is we do a finger stick check, because they could be very, very low on their blood sugar. So yeah, check their neurological status, monitor for hypoglycemia, check their serum levels of glucose. Frequent vital signs, we're going to be monitoring their heart rate and their rhythm, and then we're going to make sure that we keep them warm. Lots of warm blankets. Okay, so pheochromocytoma. This is a benign tumor that happens in the adrenal medulla that causes hyperfunction, so hypersecretion. It causes the excessive secretion of catecholamines. Catecholamines are epinephrine and norepinephrine. We see this sometimes if they had a tumor that they went in and did a biopsy on, or if they tried to maneuver it. So any kind of manipulation of that tumor can cause it. Postural changes in a patient can trigger these symptoms. It can be exercise caused, and if the patient is under any kind of emotional distress. So assessment findings would be hypertension, tremors, nervousness, sweating, palpitations, tachycardia, increased risk for a cerebral vascular attack, so a stroke, hyperglycemia, polyuria, vertigo, headaches, and nausea and vomiting. So our diagnostic findings, we would want to do a 24-hour urine on these patients. So remember, our 24-hour urine is where we're collecting it in that little brown bin. It sits on ice. We talked about that last week. We are looking for vanilla mandelic acid. If that was present in their urine, it would be present in an increased level. And then our catecholamine levels are obviously going to be increased because we're having hypersecretion. If we did a CT or an MRI, it's going to be because we are looking for that tumor. Medical and surgical management. So they may have to do a unilateral adrenalectomy to remove the tumor, it just depends. We could give them drug therapy. So we could give them metriazine or Demzer. This is an enzyme that reduces synthesis of those catecholamines, and it decreases the hypertensive attacks that the patient has. And then we can also use phenoxybenzamine, which is also used to help control the hypertension because they have such elevated blood pressure. So obviously, as the nurse, we are going to be doing frequent vital signs. We're really going to be taking a look at that blood pressure. We're going to assess for signs and symptoms of that insufficiency if we know that they've had an adrenalectomy, because we know what can happen. So this is your healthy kidneys and your adrenal glands on top. This is what it looks like here on the right if we have too much adrenaline that is released from that adrenal gland. All right, so Cushing's syndrome. Cushing's syndrome is an oversecretion of the hormones that the adrenal cortex produces. So we know it is the ACTH, which is the adrenocorticotropic hormone. We can see Cushing's syndrome develop if there has been a tumor in the pituitary gland, which causes release of that hormone. It also can result from long-term use of glucocorticoids to treat asthma and rheumatoid arthritis. So it's very, very common that patients that have had asthma for a long time, and obviously as they get older, this rheumatoid arthritis, they develop this. And it is just an overproduction of the ACTH by that pituitary gland. So we may see something called Cushinoid Syndrome. So Cushinoid Syndrome is just the physical changes that we see that accompany the disorder with Cushing's syndrome. So we're going to see muscle wasting, and they're going to be very, very weak. They're going to have very thin, fragile skin. So these patients, they're going to have bruises all over their skin. They're going to have a lot of skin tears. They might even have petechiae. Their cheeks are going to be red. They're going to have hyperglycemia. So their blood pressure, their blood glucose is going to go through the roof. They're going to have an increased heart rate, tachycardia. They're also going to have, so moon face, weight gain, and buffalo hump. So these are your, characterizing symptoms here of Cushing syndrome. So this moon face is perfectly round, very swollen and fat. They're going to complain of weight gain. You're going to be able to visibly see it on them. Probably not so much in the hospital because you don't really have anything to compare it to, but in the primary care setting, you would notice it. And then they're going to have a buffalo hump. A buffalo hump is a big fat collection that's on the back of the neck. And I think there's a picture in here I'll be able to show you. They might have striae. Remember I said they're going to have wounds, masculinization, so they're going to appear masculine, and then they can also get kyphosis of the back, which is that hump that goes in the spine. Their skin is thin, their face is going to be ruddy and red. They're at an increased susceptibility to wounds, and then if they do get a wound, so skin tears, it's going to take a long time for them to heal. Their carbohydrate tolerance is going to be lowered, so they are going to see signs and symptoms of diabetes mellitus start to develop. And they can develop gastric ulcers because of the oversecretion of hydrochloric acid in the GI system. So this is a perfect example of someone who has Cushing's disease. So you can see the hair right here on the chin and above the lymph. This is a woman, so she should not have all that hair. You can see around the neck here, she has redness up here on the cheeks, very ruddy, a little bit on the forehead. Her face is very swollen, moon-like, puffy. You can see a little bit right here on each side of the neck, how that area is elevated above the shoulders. That's that kyphosis and that hump on the back of the neck. So this is a better picture. So this shows you all the things. This is that buffalo hump. They're going to be obese. These are all the things that you can see. And this is just another fun slide for you guys with Cushing syndrome. Purple striae, that's what I talked about in the last slide. They could have petechiae, bruising, thin extremities, very, very, very thin skin. Sodium and fluid retention, so they're going to have edema. Too many corticosteroids, increased risk of infection. All right, hyperaldosteronism. This is excessive secretion of aldosterone leading to extreme electrolyte imbalances. These patients are going to have muscle weakness, fatigue, cardiac dysrhythmias, headache, increased urine output, and hypertension. Diagnostic findings, when we look at labs, we're going to be looking at serum potassium. That is going to come back as decreased. Their serum sodium is going to be increased. Their serum bicarbonate, aldosterone, and plasma renin levels are all going to be increased. Other diagnostic tests, if we had to do a CT or an MRI, it would be because we were ruling out a tumor. And we might do an adrenal venography. This would be used in case they still thought there was a tumor there that the CT or the MRI didn't pick up, then they would do that. And that's a much better test at identifying small tumors. So medical and surgical treatment, if they needed surgical management, it might be a unilateral adrenalectomy. Again, it just depends on the circumstances. Drug therapy, we would give spironolactone, which is a potassium-sparing diuretic. And then we would give antihypertensive agents to control blood pressure. So remember we said these patients already have a decreased potassium level, right? So we don't want to decrease it any further. So we want a diuretic that is going to spare the potassium because they can't afford to lose any more. And then their sodium is going to be high, so their diet is going to be a sodium-restricted diet. So from nursing aspect, you are going to want to monitor vital signs every 4 hours or as ordered. We're going to be measuring strict I's and O's, so fluid intake and output. We're going to be weighing that client every 2 to 7 days, or as per the doctor, could be daily. We are going to want to make sure that we are doing a very thorough daily examination of their extremities and their skin. We're checking for edema. And then the nurse is going to observe for signs and symptoms of hypokalemia and hypernatremia. And our last exemplar is syndrome of inappropriate antidiuretic hormone secretion. We just call it SIADH. So this is when we see renal absorption of water rather than where we normally see it excreted. So the kidneys are going to hold on to water. This will develop sometimes we see it very, very commonly in patients that have brain tumors. It happens sometimes in patients that have had strokes, patients that have head injuries. So if they've older adults that have had a fall and they hit their head, if they've been in some kind of car accident, central nervous system disorders, patients that have lung tumors, certain medications cause it. So general anesthetic, so patients that have had some type of surgery sometimes are at risk for this. Patients that take oral hypoglycemics, metformin can cause this sometimes, tricyclic antidepressants, and then vasopressin. So the continued release of ADH increases the fluid volume and causes hyponatremia, which is a decreased serum sodium level. So what are we going to see? We're going to see water retention. So that circulating fluid volume is going to be on overload. So the patients are going to have headaches. They're going to have muscle cramps because they have so much fluid. They're going to have anorexia. They're not going to feel like drinking. As this condition starts to get worse, they're going to complain of nausea and vomiting. You might see muscle twitching, or they might report to you that they feel their muscles twitching, and then they are going to experience changes in their level of consciousness. So diagnostic findings, our serum sodium levels and serum osmolarity are going to be decreased. Our urine sodium levels and osmolarity in the urine are going to be high. Medical management, so because it can be caused by so many different things, the treatment is really just going to focus on actually what's causing it. We might have to give osmotic diuretics because we want to get off all that fluid. So we can give IV mannitol. We're going to be using loop diuretics. We can use furosemide, also known as Lasix, to help correct that water retention. So we know if these patients are on any kind of diuretics, we're going to be really strictly monitoring their eyes and nose, because that's the only indicator other than looking at their edema that we can tell that they're getting this fluid off. Severe hyponatremia is going to be treated with an IV administration of 3% hypertonic sodium chloride. So from the nurse's perspective, obviously strict eyes and nose. Vital signs, you want to assess their level of consciousness. So name, date of birth, where are you, what year is it, what month is it, who's the president, all that good stuff. And then we want to check closely for signs of fluid overload. So are they short of breath at dyspnea? I mean, do they have dyspnea at rest? Do they have dyspnea on exertion? Do they appear confused? Do you hear a lot of advantageous lung sounds from pulmonary congestion? Do they have hypertension because their circulating volume is now increased because of all the fluid? Since they have hyponatremia, they are going to experience weakness. They might report muscle cramps, anorexia, nausea, maybe some diarrhea. They may seem irritable, headaches, and then that weight gain without edema as well sometimes. All right, so let's see.